All right, I think we can go ahead and get started. So welcome everyone to our webinar this morning. It's bright and early on a Monday morning, so thanks for coming to hang out with us today. Our webinar today is developing a rural sexual assault response team protocol. So we're going to be focused really on how to develop that SART protocol. My name is Victoria Riekers. I use she, her pronouns, and I'm one of the sexual violence response coordinators at the Arizona Coalition to End Sexual and Domestic Violence. Just a bit of housekeeping before we get started. So today we do have interpretation in Spanish. Hoy tenemos interpretación en español. Si necesita interpretación, puede elijar el canal español para escuchar en español. So we have Spanish interpretation. If you need to listen in Spanish, you can choose the Spanish channel on your screen. And then if you're listening in English, you can also choose the English channel if you're having any tech or audio difficulty. Sometimes that can help with any tech issues that you're having if you choose the English channel. We also have ASL interpreters today, and they should be showing up on the side of your screen. And then if you can't see them for some reason, please let us know. They should be spotlighted, but in case they're not, please let us know if they disappear at any point. If you need to get in touch with me, you can send me a direct message in the chat, or you can send a direct message to all the panelists, I think, actually. But just please note that if you do need to get in touch with me, I might not be able to respond depending on what's going on, just because I'm presenting. However, if you do send a direct message to the panelists, Lachey will be able to respond. Just please know that the direct message to the panelists will also go to all the interpreters, so it won't be totally private. If you want a private conversation with Lachey, you can always message the panelists and just say, I want to talk to Lachey, and then she can private message you back and have a private conversation. If you have any questions today, please put them in the Q&A box. This will help me out a lot because if you put it in the chat, I might miss it, depending on how active the chat is. But if you put it in the Q&A, I will definitely see it. And then, of course, Zoom bombing won't be tolerated. So just to please keep all the chat respectful. And then if there is an issue, we don't expect there to be, but if there is an issue, we will take care of it when it happens. And then also Lachey is here to help out with any tech support or logistical questions. So if you have questions about certificates or anything like that, feel free to reach out to Lachey. And then lastly, we do have an evaluation at the end of today. And then to get a certificate, all you have to do is complete the evaluation, and there will be a link to download the certificate once you have finished the evaluation. All right, so we will go ahead and get started with the actual webinar now. So our objectives for today's webinar is to do an overview of the purpose and components of a sexual assault response team protocol. We're going to look at strategies to develop a SART protocol, and we're also going to look a little bit at implementing and evaluating a SART protocol. We'll spend the least amount of time on that because we are planning to do an evaluation webinar at some point in the future. So we're not going to spend too much time on that. We're mostly going to be focusing on the development of the protocol itself today. So the first thing we're going to do is a Mentimeter poll. So if you've seen one of my webinars before, you know the drill. We're going to go to menti.com on our computer or on our phone, and then you'll enter in the code and you can answer the question. Lachey is also going to put a link in the chat, so you can just actually click that link and be taken directly to the poll as well. So you're going to go to menti.com and enter the code 65534980. Or you can follow the link that Lachey just dropped in the chat. And the question today is, the SART in my community has a protocol that was reviewed or updated within the last 3 to 5 years. All right, so we're seeing quite a few no's. So 4 no's and 2 unsure. 1 yes, so that's awesome. And there's no SART in my community for 3 folks. And so the reason I'm asking this question is because I know that there's a lot of different communities out there that are in different stages of SART development, SART protocol development, all of that. And so I wanted to see what stage everyone was at today so that I could best tailor this training to you all, and also to let you know that other folks are in the same boat as you. Right, there's lots of folks where there is no SART in their community, or there hasn't been a new protocol or an updated protocol in a while, right? And so today we are really going to focus on what we can do to update or develop that protocol. So thank you everyone for participating in that. I'm still seeing some answers trickle in. So the no category is getting quite a bit higher, right? So you're in the right place today. We're going to really figure out what we can do to update our SART protocols. Awesome. Okay, so we're getting started. And I apologize, I have a few puns in my training today. But so we've decided to form a SART, or maybe you've had a SART around for a while and you just haven't updated the protocol. We've identified the SART members and we've started meeting. Awesome. We've defined our mission, goals, and objectives. Awesome. So now what? Now that we've done all of that really initial planning and development, now it's time to develop the SART protocol. So what is a SART protocol? So our SART, a sexual assault response protocol is a few different things. So one thing that's really important is that it's going to document the policies, procedures, and agreements to how the SART is going to respond to survivors, right? So it's going to be kind of like a centralized document that really demonstrates what we are supposed to be doing. One of the purposes is to really enhance collaboration. We really identify where we are collaborating, what we can do better to collaborate when we're working on our SART protocol. We increase consistency, making sure that all survivors are getting a similar response from all different providers, right? So we're not just getting one response to a survivor who accesses services one way versus another way. We're going to try to have consistency across the board. We're also going to try to eliminate gaps, right? So sometimes there's gaps in our community where we just don't have those services. But other times there's gaps that exist because of the way we're collaborating or the way we're communicating, right? And so our protocol can help us identify some of those gaps and ways we can fix those gaps. It also defines roles and relationships, right? It can help us understand, what does law enforcement do? What do advocates do? What does the hospital in our community do, right? It's going to really define what those roles are. And it's something to help our SART last over time. The protocol is going to be multidisciplinary as well as discipline specific. So what does that mean? Basically, it's going to be multidisciplinary because it's going to cover the multidisciplinary response, but it's going to be discipline specific because it's going to have sections that talk specifically about how each discipline is unique and how that discipline responds. It's going to be inclusive of all SART members as well as survivor voices. We want to make sure survivors are included in this as well. It's going to supplement individual agency policies and procedures, right? We know that every agency, every member involved is going to have their own individual agency protocol or procedure or policy. And so the SART protocol is going to go along with that, and it's going to be used to supplement that policy. And then very, very importantly, it is a living document, right? So it's always going to be updating and changing based on the SART's needs. It's not set in stone. It's always going to be in motion. A SART protocol typically is going to contain the different expectations and standards for each member and discipline's response. Right, so it's going to contain those best practices of what these responses should be looking like and how those responses are unique to our community. It's going to have clearly defined roles and expectations for collaboration. So it's going to say, this is when law enforcement should contact an advocate. This is when the hospital should contact law enforcement, right? Different points of collaboration like that. It's going to have the confidentiality considerations of all the SART members, right? We're going to talk a little bit more about this later, but we know that every single member of the SART has different confidentiality obligations. So it's going to really clarify what that means for the SART. So when we're talking about specific cases, we're going to talk about what that means. And it's also going to clarify what confidentiality means to the other members of the SART, because sometimes some different disagreements can happen just because members don't understand those unique confidentiality obligations. And then it's also going to contain how the SART will be evaluated, right? So what that process is going to look like. Are we going to do things like case reviews, right? Or how we're getting survivor feedback. We're going to want to include that in our protocol as well. When it comes to the different disciplines, at a minimum, the disciplines that should be included are victim services, right? So all the advocates, community-based advocates, systems-based advocates, family advocacy centers, right? All the different types of victim services should be there. It's going to include law enforcement response, and ideally we're going to want all the law enforcement jurisdictions in our service area to attend. We're also going to want medical response, and this will be including the forensic examiners. And we'll want to include the prosecution response. And then as far as the other disciplines that can be included, any other organization or agency that's involved in the SART, you'll want them included as well. But we know at a minimum, a SART's typically made up of victim services, law enforcement, medical, and prosecution response. And then something to point out too is if you are a rural SART, you might want to consider inviting folks from other counties or other areas, especially if you don't have those services directly in your community, right? So some SARTs that I work with, they actually they don't have forensic examiners in their whole county. And so they actually invite forensic examiners from the closest county where they typically take survivors after experiencing a sexual assault to come to their SART. And then the SART coordinator actually attends that SART as well. So we have that cross collaboration happening. And then before you really start your protocol development, you're going to want to ask yourself, is your SART ready for a protocol? Right. And so some steps to being ready is, does your SART have a clearly defined purpose, right? Have you gone through and developed your mission statement, right? Do you know what your coverage area is going to be for this SART? Do you have representation from key members in your community, right? Is there that regular participation? It's also really important to make sure the agencies involved have buy-in from their leadership. Something that might happen when you're developing your SART protocol is that you might realize there are some serious issues with the existing policies and procedures that different organizations have. And so if we don't have the buy-in from leadership, we're not going to be able to address any of those problems because no one's going to be willing to change, right? So we want to make sure we have that buy-in from leadership. We also want to look at the relationships between SART members, right? Is the relationship really good, or do we have some problems that we might want to work through first? Sometimes the protocol development could be a good way to work through those problems, but other times it could create a more tense environment, more tense situation. And so we might want to focus on relationship building and trust building before we do the protocol development, especially if we maybe have a history of tension between organizations in our community. And then last, does your SART have the capacity or funding to develop and implement a protocol? Right, so obviously when it comes to capacity and funding, this is really, really helpful when it comes to a SART. Not all SARTs have funding though, so it can be done without funding, but funding absolutely helps. Right? It always is going to help. And so this might be something that your SART wants to look for before you start developing a SART protocol. And then if you're looking at these questions and you're like, oh no, I know my community is not ready based on these questions. We did a couple of webinars last year about really starting a sexual assault response team. And so we encourage you to check those out. Lachey just dropped the YouTube links for the recording of those webinars. And so that those are going to have more information about, right, how you develop your mission statement, how you come up with some of your goals and objectives, which you might want before you start working on that protocol piece. But if you looked at these questions and you're like, we are absolutely ready, like we have done all of these things, awesome. So now we are ready to start our protocol development. So what makes a good protocol? So there's many different things that make a good protocol. One of them is consistency, right? All victims and survivors are experiencing the same approach. Comprehensive, the SART is informed by best practices, right? We are really listening to our community, what our community needs, and then we are looking at the best practices to make sure that we are doing our jobs correctly. It's coordinated, so all of our cooperation and collaboration makes sense, and we are making sure that we are coordinating with each other. It's continuous, so we are constantly evaluating the SART's impact, revisiting the protocol, and it's a continuous cycle. It's not, we make this protocol, we're done, that's it, we're the most perfect SART ever. No, we're continuously looking at our response and trying to improve it. And it's community specific, right? So our response is by and for the community that we serve, right? I've helped different communities make SART protocols, but the one thing that I really cannot help with is making it community specific, right? Because I am based in Phoenix, I work statewide, of course, but I'm not going to know all of the nuances of your communities. And so this is really, really important to make sure you're capturing that in your protocol. And it's also important to recognize we can't anticipate every single case. All survivors of sexual violence are unique. They're going to have unique needs. But we want to make sure our SART is covering some of those basic elements of what a response is, regardless of who the service provider is. So before you SART, you can ask yourself, are you updating an existing protocol or are you creating a brand new one? Right? Maybe if your community's had a protocol, it hasn't been looked at in 10 years, maybe it might be easier to start fresh, right? Completely start over. Or maybe you look at it and you're like, actually, this is actually not too bad, so we can edit from this. Sometimes some people find it easier to edit from an existing document. Some people find it easier to just start fresh, right? It's going to be unique to what your community is like and what your capacity is like. What's a reasonable timeline for protocol development? Again, this might vary. I really think anything less than 6 months is not realistic. I think 9 months to a year, probably a little bit more realistic for creating a protocol. And we're also going to want to think about who's going to be involved with the writing and development and who is leading. Right? And you might naturally be thinking, oh, the SART coordinator is going to be in charge of that. Right? So the SART coordinator might be leading the effort, but we want to make sure that it's not just one person who's writing and developing the whole thing, because then only one person knows what's in the protocol, right? We want to make sure this is a team and a collaborative effort, but we also recognize that not everyone who's in a SART has the capacity to write and do some of these more specific things, but we want to make sure everyone is contributing. We're also going to want to decide on a development strategy. And we might decide on this before we start. We might decide on this as we go, maybe after we start a little bit. But some different strategies that I have used or I've seen being used is having discipline-specific work groups. So this would be when all of the different types of disciplines, so law enforcement, victim services, medical, et cetera, they meet in their own little work group and they talk about what the response, what kind of that uniform response is going to look like for their specific discipline. And then they bring that back to the larger group. Some SARTs have developed a protocol committee, so a smaller group with representation from all of the different disciplines in the SART who can really devote that time and effort to developing the SART. Other SARTs have used a standing agenda item at each meeting, so maybe they'll devote 20 minutes of each meeting to their protocol development. And then others have also had separate protocol development meetings. I personally am always partial to the separate protocol development meetings because then we can devote all of our time to the protocol because it does take up a lot of time. And sometimes when we only have it as an agenda item, it can feel like we're not making any progress on it. But that's just my personal preference, right? And every SART's going to be different. It's going to depend on the size of your SART, right? So if you have a really large SART, you might want to have that committee or those discipline-specific work groups. But I know for a lot of rural communities, they might only have one organization or one person represent those organizations at each meeting. So like one law enforcement officer, one advocate, and one healthcare provider. So it probably is not going to make sense always to divide up into those discipline-specific work groups, right? Because it's just one person. So it's really just going to depend on what your community looks like. Another thing to keep in mind is, do you want these meetings to be in person or virtual, right? I know with COVID, we've had a lot more experience with virtual meetings. And this might be something that would be really helpful, especially if you are in a rural county, like a really, really big one. And it may be someone would typically have to drive like an hour or an hour and a half to be able to attend this meeting in person. That could be a really helpful way to get everyone's involvement if you're in a large rural county. So what is the protocol development process, right? So on the screen, I kind of have a fun graph where we start at mapping out the services. We identify the gaps in our community. We write it down. We write down the protocol, what those gaps are and how we're fixing them. We implement the protocol. We monitor and evaluate the response, and then we start over, right? So it's this continuous process of mapping, identifying, writing, implementing, and evaluating, right? We'll just keep doing that over and over again. But this is going to be kind of the framework of today's presentation and the framework that I've used when helping communities develop their protocol. So step one, map the current response. And so when we're talking about this, we want to map the response as it is and not necessarily what we want it to be just yet. We're going to map it as it is. So we're going to take a detailed review of the sexual assault response in our community. It might be helpful to ask all members to bring their current protocol, like their internal protocol, to the mapping session. That could be helpful. We could use different case scenarios. If we do case reviews in our protocol or in our SART, we might find this to be helpful. Especially if we have an older SART where we're not creating a brand new protocol, but we're updating an existing one. We want to look at why members respond as they do. And then as we map, we'll also talk about any changes or barriers that we need to as we go. We want to look at it from a strength-based approach. So we want to focus on what are the available resources. We don't want to necessarily focus on what services just don't exist, because there's only so much a SART can do about services that don't exist in our community, right? It would be great to have them, but there's only so much we can do about it. We also want to make sure we're looking at the most effective response. And then we'll also be identifying any gaps in the response. And when we do this, we want this to be solutions focused, right? We also want to make sure we're including survivors as we're mapping, right? Because when we map out our response, we know exactly how it's supposed to happen, right? What the perfect response would look like. But we know that survivors aren't always receiving the perfect response. So we want to get their perspective of what it is actually looking like from their experience as well. They can better help identify some of those gaps in services and in collaboration, because sometimes when we do these mapping activities, we'll start to think about what is the perfect response rather than what's actually happening. And we want to know what's actually happening for this step. So some ways to include survivors is we could do surveys, focus groups, interviews. There's a lot of different ways. And we have a resource called Listening to Our Communities. And this is a really great resource that has a lot of information about how we can do a community assessment in our specific community to find out what the response is looking like from other people's perspective, right? And Lachey has just dropped that link in the chat for everyone. We also want to think about how we're going to analyze the response when we're mapping, right? So some common frameworks that we tend to use is an anti-oppression framework, right? So when we use an anti-oppression framework, we want to think about how is the sexual assault response team reaching the last girl. And so if you've attended some of our trainings in the past, you may be familiar with the last girl, but the last girl is a concept that we use to talk about how we are reaching the person who is the least likely to come into our services to reach out for help after experiencing a sexual assault. This person the concept's called the last girl. This person may not be a girl, but we want to look at our community, reflect on who is in our community. And the last girl may be a trans disabled woman, right? There may be many different aspects to someone's identity that may prevent them from reaching out for help. There may be many systemic barriers as to why they would not reach out for services. And so we want to think about this person when we are creating our response to make sure that we would be able to reach this person. We also want to use a victim-centered lens. Right? So how are we centering the survivor in our SART? How are we allowing the victim to make the maximum amount of decisions in this process, right? And then we also want to use a trauma-informed lens. So how is the SART actively preventing re-traumatization in this response? I'm seeing in the chat that some folks have been kicked out of the meeting. So I'm so sorry that that's been happening to you all, but I do want to make sure you all know this webinar is being recorded. So if you're getting kicked out because your internet connection is not working very well, you will be able to watch it. We'll post it on our YouTube channel shortly after the webinar. All right, so now that we kind of have a framework for understanding the mapping process, we want to get started. And like I said before, we want to focus first on what it currently looks like, right? So some different places to start might be the victim walks into a local hospital and discloses that they have experienced a sexual assault. What happens? Or they call 911, they walk into a police department, they walk into the local Family Advocacy Center, or they call a community-based programs hotline, right? There's obviously much more to this list, but we want to think about what are those entry points for a survivor to receive services or to report or to receive healthcare, right? We're going to want to look at what are all of these different entry points and then start the mapping from there. As we go, we can ask, is this response working for our community? How is the sexual assault response team being activated? And by this, I mean, how are we collaborating, right? So if a victim walks into the hospital, how are the other members of the SART potentially being notified about this? Is there a more victim-centered way we can respond? Right, so we look at the map and we're like, actually, this response isn't super victim-centered. What can we do to change that? How are marginalized identities potentially being harmed? Right, we know, especially with sexual assault response teams, because they tend to do focus on that criminal justice response, right? We know that there is some potential that marginalized communities may be being harmed in this response just because of the history of the criminal justice response, right? And so we want to make sure that we are really proactive about this not happening in our community, right? So we want to look at that. What are the strengths of our current response? What are the challenges of our current response? How are we following trauma-informed best practices, right? So maybe we have a lot of really good collaboration, the SART's being activated, we have really clear maps that everyone understands, but maybe they're just not trauma-informed, right? So we might need to make some adjustments. And what agreements can we make about moving forward with our response, right? So like I said before, something that might come up is that we need to change our own internal policies to improve the SART response. And if we can't change those policies, then we won't be able to change that in the protocol for the SART. So we want to be really clear about what we can and cannot change. For rural communities, some additional questions you might want to think about is, what does that response time look like, right? How long do survivors have to wait for an advocate or a forensic examiner? One community that I helped with their SART, they would have to drive about an hour, hour and a half to get a forensic exam. And then when they arrived at the facility, that was when the forensic examiner was contacted. So then they'd have to wait another hour for the forensic examiner to show up, right? And so that was a really important question for them to look at when they were trying to figure out, how can we make this response more victim-centered, maybe a little faster, right? We also want to think about, how is confidentiality being protected in the response given the small community? We know that in small communities, a lot of people know a lot of different people, right? Everyone knows everyone. I grew up in a really small town, so I totally know what that feels like. And sometimes we might be talking about a particular case, and just because of the details of that case, even if we don't share any personal information, we don't share anything that normally would identify this person, because the community is so small and there's only so many responders, they can actually identify who that person is. And so we want to make sure that we are being very clear about confidentiality in those small communities. Okay, so now I have created a few sample maps of 3 different communities for us to take a look at. So the first map, a victim walks into the ER is the starting point. The hospital calls for a victim advocate. The hospital calls law enforcement to report. And they also specially note that the victim has the right to refuse to speak with law enforcement. The advocate provides advocacy and discusses options with the victim. And so these options look like not reporting and only receiving medical treatment. So then in that case, the hospital resumes care, the advocate stays to provide support and advocacy, and the victim is given information about the local advocacy program. The second option is to receive a forensic exam and delay reporting. The hospital provides that forensic exam. The advocate stays to provide support and advocacy and information about the local program. And the third option is to receive a forensic exam and report to law enforcement. So the hospital again provides the forensic exam, the advocate again stays to provide support and information about the program, and the victim and the advocate work together to contact law enforcement. So mapping number 2, this is when a victim calls 911, and this is going to be a different community. In this case, law enforcement sends patrol to the scene. Patrol takes the initial statement. The patrol screens for a medical forensic exam, and then if the sexual assault occurred within 120 hours, patrol will offer the option of a medical forensic exam. The patrol contacts the detective. The detective arrives on the scene and contacts the advocate. And then our third example, the victim walks into an ER. The hospital screens the victim for injury and for the forensic exam. The hospital calls law enforcement to report. The hospital and law enforcement collaborate to transfer the victim to the closest forensic exam facility, which is 3 hours away. The victim waits an additional hour for the on-call forensic examiner. The victim receives a forensic exam, and the victim meets with an advocate after the forensic exam. And they learn that to continue receiving advocacy, they would need to drive 3 hours to that facility. All right, so now we have these three maps, right? And we're gonna go into an analysis of the three maps in just a second. I apologize, I have a bit of a frog in my throat. I don't know why, so I'm just drinking some water. All right, so step 2, identify gaps and identify solutions. So now we're gonna do an analysis of those maps and really figure out what we can do as a SART to improve some of the gaps that we may have identified. Some guiding questions for this part is, are there any gaps in services? Are there any gaps in collaboration? Right, those are probably the two areas we're going to be identifying gaps in. How is this response victim-centered, trauma-informed, and through an anti-oppression lens, right? So we're going to use some of those questions we talked about earlier to guide that analysis here. And what can the SART do to fix these gaps? How can we change our collaboration to fix these gaps? Do any of the members need to change their internal protocols to fix the gaps? And then, is the response in compliance with all federal and Arizona laws? This is a very important one that we don't want to overlook, right? All right, so we're going to look at example 1. So in the chat, I want you to see, tell me what some of the strengths of this map are. What do you see that looks really, really good? So think about how is the SART being activated? Are we following best practices? What does that look like? What are some of the strengths? So someone said client choice guides the process. Yeah, so the question is, what are the strengths of this map? So if you look at this map, what are the strengths that you identify? So you can think about, how is the collaboration working? Are we using best practices? Yeah. So there's a lot of options available to the victim, and there's an advocate available through the entire process. Yeah, definitely a strength. What else? All right, so some strengths I identified too. So I put a gold star on all of the points where the SART is activated, right? So the hospital calls for the victim advocate. So that's a collaboration point. And the hospital calls for law enforcement. That's a collaboration point. And then when the victim wants to report to law enforcement, the victim and advocate collaborate to contact law enforcement. So another collaboration point. And then, like you all mentioned in the chat, there's also the advocates there from a really early point. So that's a huge strength. And that's also a best practice, right? When the advocate's there as soon as possible. And then they're providing lots of different options. Are there anything that you all could see that you would want to change about this map? Yeah, so someone also just pointed out that even the hospital is advocating that the survivor has the right to refuse to speak with law enforcement. Yeah, so that's that victim-centered piece. So anything that we would want to change about this map? All right, I'm not seeing anything come into the chat about what to change, but I have a couple of ideas. So the first one is there's a little bit of overlap where the hospital calls law enforcement to report, and then the victim advocate and the advocate, and the victim and the advocate are working together to report, right? And so we know in Arizona, there's a law about hospitals having to report when there's a gunshot wound, a stab wound, or material injury from a crime. And so it's a little bit vague, but some hospitals have interpreted that material injury from a crime includes sexual violence. So they will call and report all sexual violence crimes. This is, it's unclear in the law. And so we definitely recommend taking a look at hospital policy to see if we do need to contact law enforcement, right? So if we need to contact law enforcement, or if we actually can wait to see if the victim wants to contact law enforcement. So I've actually seen different communities change this policy altogether, and they've stopped contacting law enforcement until the victim decides if they want to or not, which is a little bit more victim informed, right? But if you're working in a community and the hospital's lawyers are like, no, we have to follow and contact law enforcement, that's okay. Some things we can do is figure out what's the most victim-centered way to contact law enforcement in this scenario, right? Maybe instead of contacting law enforcement right at the beginning, they wait until the advocate gives those options, and they still contact law enforcement for those the victims who don't want to speak with law enforcement. And they're really clear about how the victim does not need to speak with law enforcement, and that they just have to follow this law, right? All of that. But we might be able to make this a little bit more of a seamless process. So that's my recommendation for this map. I'm seeing a question: do the hospitals have the approved kits to perform the sexual assault exam? They would have to call a SANE nurse to bring the kit. Yeah, so in this example, this hospital has a forensic exam program, right? That's why they don't need to transfer anyone, and they don't need to wait for the forensic examiner to show up, because the forensic examiner is already there, right? So that's definitely one of the benefits of this map. I would say this map is a little bit more of an idealized situation, but there were still some things that we could improve about it. But definitely for other hospitals, if they don't have a forensic exam program, or maybe they have like a designated room for the forensic exam program, but they have to wait for the forensic examiner to show up or to bring the kit, all of that stuff, it's going to look a little bit different. All right, so now this is kind of the results from example one. So the service gaps, this one actually looks pretty good so far. We've got a lot of collaboration. The services are happening, and we might need a little bit more information about individual cases to identify more specific service gaps. And then the collaboration gaps, collaboration looks pretty good, but it could be a little bit more victim-centered as far as law enforcement being contacted. Those are some of the main things we identified. All right, so now we're going to look at example two. So this, again, is a different community. So what do we see in this map? What are some of the strengths? So how is the sexual assault response team being activated in this map? And how are we following best practices? What are the strengths that we see? Yeah, so one of the strengths is screening for the forensic exam, definitely. Right, so I marked that one as well. Any other strengths that you're identifying? Yeah, and they're contacting the advocate. Yeah, so the detective contacts that advocate when they arrive. Awesome. Yeah, so those were the two collaboration points I also identified as strengths. Are there any gaps that you all are seeing? Anything that you would want to change about this map to make it better, to make it more victim-centered, to make the process easier for victims, anything like that, more trauma-informed? Patrol taking the initial statement for prosecution. So you're identifying that as a strength, it sounds like. So yeah, so it's really important to take that initial statement and to have that really be clear. But so what are some gaps that we're seeing? Is there anything that you would like to change about this map? Yeah, so there's no victim advocate contacted or present, um, right, uh, until that very end. So I'm missing the dispatch response. So that's more because I just didn't fit it onto the map here. But so that dispatch response is law enforcement sending patrol to the scene. Yeah, so one person said they would like law enforcement to contact a victim advocate sooner. Yeah, that's what I also would like to see here as well. And so I've suggested a couple of ideas of how we can contact that advocate sooner. So maybe we could work with dispatch about how to contact advocates. So we could give dispatch if we have a specific number we'd want them to contact, like our helpline. We can have dispatch contact us, and then we can send out an advocate to the scene. Or we could have patrol contact an advocate. I know sometimes something that's been raised in different communities is they need patrol to go out first to make sure the scene is safe for an advocate to show up. And so once patrol has identified the scene is safe for a victim advocate, then they can go ahead and contact the victim advocate, right? And so both of those ways, we would get that advocate to arrive a lot sooner than the detective, right? And so that way, the advocate might be able to be present for that initial statement, and they could help provide some of those options that law enforcement just might not know about, right? So it's great law enforcement is providing the forensic exam as an option, but maybe a survivor just wants regular healthcare, right? They don't want a forensic exam, they just want to see a doctor. Maybe they just want like an STD test or something. And so an advocate can help them figure out what's the best place to go for that instead. And what are those additional victim services that would be available? Awesome. Another thing that we might want to think about is, so patrol is contacting the detective right here, and the detective is arriving on the scene. But does that actually need to happen at this moment? Right, we know that for the in-depth interview that law enforcement's going to do, that actually is best practice to do that after 2 sleep cycles, right? Because right after someone's experienced sexual violence, their body's flooded with all of those hormones, all of the neurobiology of trauma response, that's still going on in their system, right? And that doesn't really make for a good interview, right? And sometimes when survivors are interviewed too soon and then they remember more details or they want to follow up with more information, if that case then goes to trial, the defense will say that they were lying originally, right? And so one thing that we might want to consider is actually having the detective contact the victim a few days later for that in-depth interview instead of doing it right away. And so then again, is more important for either dispatch or patrol to contact that advocate, because if the detective is actually going to contact them later and they're the main person to contact the advocate, then that advocate's still going to be missing from this piece. So again, with this map, the services look pretty good so far, right? We don't have gaps in services so far, just some gaps in collaboration potentially. And we can make those collaboration gaps a little bit better and a little bit more victim-centered, especially regarding how the victim advocate is contacted. All right, so now we have the third and final example. So in this example, the victim walks into the ER of the local hospital, and the hospital calls law enforcement to report, and they screen for injury and for the forensic exam. They are transported to the closest forensic exam facility. They wait for the examiner to arrive. Once they get there, they do receive the exam and they do talk to an advocate, but they learn that that advocate doesn't really cover the area they live in. So what are some of the strengths of this map that you're seeing first off? How is the collaboration working here? Oh yes, and someone raised a good point about the other map that we just moved on from, but so they have, there's a community they're aware of where law enforcement contacts the detective and they come to investigate the scene, but they don't do the interview until later. So yes, that's definitely the best practice. But so now looking at this map, what are some of those strengths that you're seeing? Yeah, so collaboration to transport the victim to the forensic exam facility, definitely. That is also what I have identified. Yeah, the hospital screens and contacts law enforcement quickly. Yeah, and it would be nice if there was an advocate contacted. Yeah. Yeah, so far there's only an advocate contacted after the forensic exam. So it's been about probably 6 hours between walking into the ER and talking to the advocate, right? So if it's like 4 hours to get the exam, and then maybe the exam takes another 2 hours, right? 6 hours to talk to an advocate. So that's quite a bit while. Yeah, and they're collaborating with the nearest forensic exam facility. That's awesome too. What are some of the gaps that you're seeing? So there's a significant lack of resources nearby or in the community, definitely. Yeah, the forensic exams aren't available. It's long distance. Absolutely. Advocates need to be called sooner, definitely. Yeah, and based on this map, we actually don't even know if there's an advocate in the community to be called. I made this map, so I do know, but based on the map alone, we don't know. But yeah, so this map, because I created this like hypothetical map, right? In my scenario, this map was actually created based on the survivor feedback. And so that's one of the reasons that it's not clear if there's an advocate in the community, right? Because this particular survivor didn't have any advocacy services offered to them locally. Yeah, so there's a disconnect between the initial hospital and the second facility because they had to wait an additional hour, definitely. Calling the forensic facility sooner so the survivor doesn't have to wait so long. Need for better coordination, definitely. Yeah, so those are all really, really great points. But so the survivor who helped create this map had this, and then when the SART met to talk about this, they were talking about, well, there's actually a local advocate based at the community health center, but the hospital staff and law enforcement patrol weren't aware of them. So they were never contacted, right? So because of this, there are so many different points where this local advocate could have been involved in this entire process. And then the survivor would not have been told at the end that they have to drive 3 hours to receive advocacy, right? So there's pretty big service gaps, which is to be expected in any community. We know not every community has forensic exams, not every community has a lot of advocates, right? But there's also some pretty big collaboration gaps happening here. And I feel like you've identified all of the ones I identified as well, right? So there's no forensic examiner in the community, and this community only has one local advocate, right? So some pretty big service gaps, but a sexual assault response team can't really do too much about those service gaps right away, right? That might be a longer term goal, but not something that we can fix with just the protocol. But some of those collaboration points that you identified, the hospital and law enforcement are collaborating well, so that's great. But the local advocate wasn't contacted. So how can we fix this? So this might look like working with the hospital to change what their internal process is. So maybe the hospital can call the advocate. That's like a pretty simple change. I say simple, obviously it's gonna depend on the hospital and all of that and the relationships that you all have. But this is something that I've seen be done in many different communities, right? Where we can change the hospital's response. This could also be another way if we're changing law enforcement response to contact the advocate sooner. So just so that advocate is contacted. Many of you pointed out that there's that disconnect between the hospital and the second facility. So how can we fix that? So maybe when they are in transport to the second facility, they give that second facility a call, and the second facility knows that they need to contact the forensic examiner so that they arrive around the same time as the advocate. One thing I've seen is that there was one place where they had on-call forensic examiners, but they would only be contacted, they only could be contacted by the advocate who worked at that particular facility. But then they realized that a very similar problem was happening where the survivor would have to wait about an hour to receive the forensic exam after arriving. And so they were able to get clearance for particular advocates in the one community to be able to call the forensic examiners as well to eliminate that gap. And then the advocacy program that's 3 hours away, they didn't know the local advocate existed either. So how can we fix that? So we can work for better collaboration between victim service providers who are nearby and really get them communicating so that if this happens again where there's a survivor who goes to this particular facility and no advocate's been contacted, that the advocates at that facility, at least, they know about the local advocate who is available, right? So there's a bunch of different points where we can make this map a little bit better in terms of collaboration. All right, and then I saw a comment about waiting 2 sleep cycles and how that can be a problem. However, I do know, so as when it comes to trauma-informed interviewing of survivors, waiting 2 sleep cycles is considered best practice because of the way that all of those hormones released during trauma affect the brain and affect memory, right? And so when someone is still having those impacts from maybe they're dissociating, maybe they are not able to remember things very well. Sometimes if they're interviewed too soon, the information can be really unclear, and can be seen as if they're withholding information, right? And this is a significant problem that's been recorded across the country, right? So it's really important that we do have that waiting of 2 sleep cycles. Now, of course, when it comes to other evidence, like the forensic exam or any evidence on the scene, that absolutely we would want to collect right away, or even if you can do suspect interviews, the sooner the better, or witness interviews. But when it does come to the victim themselves, it is very much considered best practice by trauma interviewing specialists to wait a little bit so that the survivor can remember things better. So now we're on to step 3. So we've mapped the process, we've identified the gaps and how to fix them. So we're going to write it down, right? So we're going to take a look at that current mapping that we've done. We're going to figure out what solutions we can and cannot do, right? So some of those solutions we might be able to implement right away. Some of those might take a little bit more time. We might need to work with different service providers to figure out how they can change. It's going to be a little bit more of a gradual process. And we want to identify what should be happening and have clear agreement about what should be happening in our community. And then we want to write down what should be happening, right? And that's really the basis of the protocol. Some ways to get started, because I know writing can be really intimidating sometimes. Sometimes we can update an existing protocol. So maybe we already have that starting point and we just need to update it. Sometimes we can create a brand new protocol. One thing I would recommend if we're creating a brand new protocol is to use the Arizona guidelines for coordinated community response to adult sexual assault. Right, so this is something that we at the coalition created in coordination with the governor's office. And it's really designed to be kind of like a draft protocol for communities to use. And I've literally seen communities take it and just go through it section by section, remove all the sections that don't apply to them, right? So like there's a section about crime lab. Your community might not have a crime lab, so like you don't need that section, but they'll go through section by section and then tailor it and really make it specific to their community. And sometimes that can be a lot less intimidating than starting from a blank piece of paper, right? And then one of the benefits to the protocol or the guidelines is that it also has all of the Arizona laws about confidentiality, all of the victim rights laws, all those laws that that sexual assault response teams need to be following, right? So you can use it as a draft, you can use it as a guide if you want. And then another thing that communities can use is just sample protocols from different SARTs. And so Lachey has just put in the chat the link to get the guidelines and a link to get some sample protocols from the National Sexual Violence Resource Center. If we're updating an existing protocol, we're going to want to review to see if it's accurate to the current response. One thing that we might find as we're mapping it out is that the existing protocol has nothing to do with what's actually happening in the community. And we're like, oh, this is a problem because we're not following our old protocol. So we need to figure out how to better implement this new one. If it's accurate, we can make simple changes to update it and improve our new identified response. If it's not accurate, we want to check in with the mapping process, make sure we know where it's going wrong. So like maybe it's not accurate because the old protocol is actually exactly what we've just identified and it's not happening. So how are we going to improve that? How are we going to make sure that it's happening this time around? And then again, if we're updating an existing one, we can use the guidelines as a resource. If we're creating something brand new, we can use the guidelines as a draft, like I mentioned. We can use other communities' protocols. Some other ways to start too is we could start with the internal protocols that we have and then edit them into that identified response. We can also have each discipline write their own section following the identified response. right? That can be a really good place to start too. In addition to recording that response that we want to see happening, we want to make sure we include those guiding frameworks that we used to analyze our maps. So being victim-centered, being trauma-informed, and having that anti-oppression lens, and what those things specifically mean for your team. We also want to look at how the SART will be evaluated, right? Are we going to be doing regular surveys with survivors or regular focus groups? Are we going to be doing case reviews? Are we going to look at closed cases, open cases, right? What's all that going to look like? We can also include training recommendations for members. So maybe we're like, all law enforcement detectives should be trained on trauma-informed interviewing. All forensic examiners should be trained on the neurobiology of trauma, right? Different things like that. And then we also want to make sure we include a section about confidentiality obligations. And so just to make sure we're all on the same page about that is SART members really have very different confidentiality and discovery obligations, right? So folks who are in law enforcement or who are prosecutors, they have discovery obligations. So if they learn something about a case that's new information, they may be required to share that with the defendant or the perpetrator, right? And that might need to be added to the investigation. And so we want to make sure that advocates are not sharing too much information or information that law enforcement and prosecutors don't already have, right? Because this could be a significant violation of all those federal and state level confidentiality guidelines that advocates have to follow, right? And it could also be very harmful to the survivor if some of that information is shared. So we want to make sure it's super clear who can share what, and that if advocates aren't sharing information or if forensic examiners aren't sharing information, it's clear why that's happening. And so that way law enforcement and prosecutors aren't being frustrated with the advocates because it's just clear that they are following the law about confidentiality, right? We also want to talk about case reviews when we're having this confidentiality discussion. So some communities will do case reviews as a way to evaluate their SART. Some SARTs will do case reviews for a particular case if there's like something going wrong or something is happening that's out of the norm. They might want to talk about that particular case, which is a really important function of SARTs. However, when we talk about open cases, there's a higher chance of confidentiality breaches, right? And we always want to make sure this doesn't happen. So some ways we can talk about this is making it really clear who can and can't be involved in case reviews, what case types, so open or closed cases, should be involved. And then in some communities, I've seen that the prosecutors are just not comfortable with open cases being part of the being part of the SART team. And so they just do not do it for that community. Oops. And now we just have a brief video about confidentiality.
When it comes to addressing privacy and confidentiality issues in a SART, I think it's often both a strength for SARTs that they are multidisciplinary, so that they bring together law enforcement and the advocate community and a prosecutor and maybe a healthcare provider or school representatives. I mean, every SART is different, and every profession, and depending upon funding, sets of professionals are governed by very different privacy and confidentiality obligations. So some clashes or differing perspectives are inevitable because these individuals have different perspectives, different obligations, and having that conversation at the very outset and repeatedly, because there's turnover, people forget, et cetera, is so critical to SARTs being able to work together. When someone is unwilling to share a survivor's personal information, it's not that they don't trust their colleagues on the SART, but rather maybe the survivor has requested certain information not be shared. Maybe they're funding the federal laws, such as the Violence Against Women Act, the Family Violence Prevention Services Act, or the Victims of Crime Act, all of which have confidentiality provisions, prohibit them. They may not, under federal law, share that information without the survivor's consent. So I would ask them to take a step back and say, what are you trying to accomplish? And what are the different avenues for trying to accomplish that? And start by building trust, recognizing that everyone who comes to the table has something important to bring, and that you aren't always going to be advancing your goals by sharing survivors' personal information. In fact, by trying to force that hand and make that happen, it may have the absolute opposite reaction, that you may not get the participation that you want. You may get survivors who stop coming forward because they don't want their information disclosed in this context. It really is, are we providing survivor-centered services in our community in a way that makes it safe for survivors to come forward, to have their needs identified, and for us as a community to address those needs.
And then, now that we've written it down, we've got it all in place, we want to implement the protocol. So some different ways we can implement the protocol include renewing the commitment of leadership at agencies who are involved in the SART. Right, so if there's some significant changes to the way that different agencies need to operate, we need to make sure that the agency leadership's on board. We might need to renew our memorandums of understanding, our MOUs, update them, create new ones, depending on what's gone on in the development of this protocol. We could consider having a public event or press conference to take the time to share and celebrate that we have created this protocol. This can help let the community know that there is a clear process in place for what should be happening when someone experiences sexual violence. We also will want to identify the SART members who can train on the protocols, right? Some people in the SART might be super comfortable giving trainings. Others may not want to train. They might not want to do any public speaking at all. So we want to find out who can train. We want to make sure the entire SART is trained, especially if the SART was if the protocol was developed in like a committee or in a work group. We want to make sure that the entire SART who was not involved in the development of the protocol is included in the training and they have a clear understanding of what's going on with the protocol. And then we also want to identify who in member organizations need to be trained. Some things to think about with the training is what SART members are going to be most affected, right? So if we're going to change, perhaps in this protocol, we have identified that dispatch is going to be calling the advocate and also sending them to the scene. We're going to need to train dispatch, right, on what they're going to need to do to know when to call an advocate and how to do that process. Right, so we're going to take a look at all the different disciplines, look at what's changed, look at what needs to happen and who is implementing those changes and who is really the first responder of each of those disciplines. We're also going to want to think about how many people at each member agency need to be trained, right? Do we need to train 80% for the SART protocol to be considered implemented, right? Like how many people need to actually be trained? What's the timeline, right? We want to set ourselves a timeline because, you know, sometimes if we don't set a timeline, we might put it on the back burner and not get those trainings done in a timely manner. We want to think about how new staff will become trained, right? Are we going to record the previous training so new staff can watch them? Are we going to have someone come in maybe once a quarter to train all of the new staff on the protocol? What are some other training needs that the members of the SART have, right? And how can we get those training needs handled? Finally, step 5, monitoring and evaluation. We want to have a continuous process for what this is going to look like. And like I said, we will be having a webinar sometime soon about evaluation. So we're not going to spend too much time on this, but it's really important to evaluate. And it's important to have this in your protocol because we know the research shows that SARTs that evaluate themselves often have better outcomes in their community. And there's 2 different types of evaluations we can look at. We can do process focus. So how is our team actually working? What's the process of the SART looking like? And it can be outcomes focused. So is the SART doing what we say we're doing, right? So if we want a process focused evaluation, we're really going to be looking at the quality of our relationships with each other. So is everyone having a strong relationship with each other? Are we collaborating the way we say we're going to be collaborating? Are we working well together? We're also going to look at the team's infrastructure and development, make sure we're still in line with the protocols. And we also might even look at our team's administrative functions, right? So how are the meetings going? Does the SART coordinator need support? And then as we do this, we want to document our accomplishments so that we can build on what's working well, as well as identifying any ongoing issues that we need to work on for improvement. If we're doing an outcome-focused evaluation, we want to look at what's happening that we didn't expect, right? Is there anything that's gone wrong? We want to look at how service providers and victims interact. Right, I know in different SART meetings, I've seen different folks bring back times where they've had problems or they've witnessed issues between particular service providers and victims and how maybe someone was re-traumatized. So we're going to want to look at that. Is that happening in our community and what can we do about it? We can look at emerging issues and how they're being addressed. We can also look at short and long-term outcomes associated with the team's activity. So this is, are we doing what we're saying we're doing? And then we can assess the impact of multidisciplinary collaboration on victims' experiences in general and the criminal and civil justice outcomes, right? So is there an improvement in the criminal and civil legal issues we're seeing in our community? And then we want to repeat everything over again. So we always want this to be a continuous process. We should always be moving on to the next part of the cycle. At whatever point we are in this cycle, we want to keep it moving and make sure that our protocol is really a living document and is really something that is being used and followed really by our SART. All right, so now I have some resources for you all to use. So I have some tools here that are specific to protocol development. That all of these are linked. So when you finish the evaluation, you will be able to download this. I have some additional sample MOU. So I know Lachey dropped a few MOU examples in the chat. So here's even more. And some of them are discipline specific, so some of them are from the perspective of forensic examiners in a SART, right? But a lot of them are really SART or coordinated community response focused. And that is it today. So here is my contact information. And Lachey has just put the evaluation in the chat. So feel free to fill that out. And then if you do want a certificate or the slides, you will need to fill it out to be able to access them. So that's it for today. So feel free to complete the evaluation, and we'll stay on for a few more minutes if anyone has any questions.